Is everybody in?
They're still coming in.
Okay.
Cora, I still show a Pia Johnson trying to get in. Is that what you're showing?
Yeah.
Okay.
Yes, and I don't.
Yeah, it's okay. It's her connection.
Everyone.
Yeah, it must be a connection on her part.
Maybe, and she's been in the waiting room for a while now.
There, she's in. Okay, Chris, whenever you're ready.
Okay, I'm ready. I will note though that I keep getting a flash saying that my internet is unstable, so you may freeze or I may freeze. But anyways, hello and welcome. This is the pre-rulemaking advisory committee meeting for considering a definition of the term normal consumption, as that term appears in Labor Code 6403.3. My name is Chris Grossgard. I'm one of the two Assistant Chiefs Counsel for the Division of Occupational Safety and Health. I'm going to be the moderator for this advisory committee meeting. There are several other DOSH representatives on this Zoom call, so I'd like to have them introduce themselves, please. Cora, why don't you start?
Yes, good morning. My name is Cora Gerga, and I work at the headquarters as Assistant Chief of Enforcement Administration. Thank you.
Amalia?
Good morning, everyone. This is Amalia Naika. I'm with Research and Standards, and I will be assisting DOSH Legal today.
And Deej?
Hi, my name is Deej, or Deborah Gold, and I'm a retired annuitant working with Research and Standards, and I'm assisting with the meeting today.
All right, Deej appears to be muted.
Appears to be muted.
No, she's good, Chris.
Okay.
I did hear her.
All right, perhaps I didn't hear it. So, Kathy, could you introduce yourself and give some technical housekeeping instructions?
Absolutely. Good morning, everybody. I'm Kathy Armis, a Senior Safety Engineer with the Professional Development and Training Unit. I'll be assisting in this meeting today technically. So I just wanted to, I'll be in the back room assisting for all your technical needs. So just a few things. I know some of you have already gone through this, but just for those who haven't, who are new to this, this is the gallery view. As you can see, to change it from a gallery view like this, the top right-hand corner of your screen, you can pick this view or the speaker view. This is a speaker view where you'll be seeing the speaker only. Whoever is speaking, their screen will flash. This is going to be the shared screen with view. I'm not sure if a document or anything is going to be shared, but if it is, the document will be on your left just as you're seeing this now, and maybe the speakers will be on the right. This is the important part, the control panel view. It should be on the bottom of your screen. If you can't see it, just move your mouse to the bottom till it shows up. You'll notice the different options you have. The important ones are mute, start video, and chat. And should be a reaction option as well. Obviously, to mute and unmute, if you can see that these are highlighted, one of these, this is how you know if you're unmuted or not. So when you do speak, you'll be asked to unmute yourself, and you'll also be asked to turn your video on so that you can be seen. If you're looking at the participants view, you'll be able to see these functions on your right.
Okay, is that it,
the same thing for, no, not yet. This is the chat thing. If you guys want to send a chat, a question, to one of the panelists or a message or a comment, please put it in here. We'll be reviewing that as well. The most important one is the hand raising. When you want to make a comment or question, please raise your hand. It's the blue, hopefully everybody has that option. It'll either be on the participants window at the bottom, or it'll be in the reaction screen at the bottom of the control panel. All right, so raise hand feature will get you, you'll be called by one of the panelists, and to unmute, to start your video, and to state your name and your affiliation. And with that, Chris, you're good.
Okay, thanks very much, Kathy. I have to confess that I didn't hear all of that because I'm trying to chase a stable internet connection, and I do apologize for that. One thing I think Kathy was going to say, and perhaps she said it, is if you're not actually speaking, could you turn your video off? And also, could you mute yourself? And that might make it easier for the capacity of Zoom. So, okay. I'd like to talk first about the purpose of this meeting. Last year, Governor Newsom signed AB 2537 to put Labor Code Section 6403.3 into the Labor Code. Most relevant to this meeting, Labor Code Section 6403.3C1 requires general acute care hospitals beginning this April 2021, April 1st, to maintain a stockpile of specified equipment sufficient to last for 3 months of normal consumption. An employer who fails to maintain the adequate stockpile can be assessed a civil penalty of up to $25,000 for each violation. The problem is Section 6403.3 doesn't define the term normal consumption as it appears in the statute. So that's what we are going to be doing through a regulation. So this is going to be a DOSH administrative regulation. So we will be promulgating it because we have the rulemaking authority. It's not an Occupational Safety and Health Standards Board regulation. So as part of the promulgation process, we've got 3 alternative options for the regulatory language that we've distributed to you. And what we want to do today is get your feedback on those 3 options. We want to hear what you like, what you don't like, what you think would work, and what wouldn't work. Once we get your input and consider your input, we'll decide upon which option works best, and then we'll promulgate that option as an emergency regulation first. And hopefully, if all goes well, we'll be able to get it into place by April 1st. So after it becomes an emergency as part of the emergency rulemaking process, you will be able to provide comment to OAL, because we'll send out the language to everybody who's here on this meeting. And you'll have an option to comment during, I think it's a 5-day period, to the Office of Administrative Law about the proposal that we've put forward to promulgate as an emergency. Then, in order to make the regulation a permanent regulation, we have to go through what's called the Certificate of Compliance process, and that's a regular rulemaking. And during that process, we'll have a public hearing at which anybody can come and speak and give public comment about the proposed regulation before it becomes a permanent regulation. And during that process, we have to take all of your comments, whether verbal or written, respond to all of those comments in what's called the final statement of reasons, and submit that to the Office of Administrative Law as part of the rulemaking process. So you will have the opportunity to make comment about the proposal. Again, this meeting, though, is not part of the official rulemaking process. It's a pre-rulemaking advisory committee meeting We just want to know what you think about our proposals. We want to talk about the proposals, get your input before we go forward with the emergency rulemaking. So again, there are three options. The concept, and everybody has copies of those options. They were part of the agenda. So the overriding concept for all three is to use past consumption data to determine how much PPE and other specified equipment you have to keep in your stockpile. However, according to each employer's effective written procedures that you're required to have under the statute, the stockpile might have to be adjusted if there's been a change, for example, in your staffing, in the types of services you offer, in different units. You might have new units, or you might get rid of a unit. The hospital might grow, or it might, offer fewer services, so that the amount that you're going to have, your needs are going to change, and so therefore your consumption and the amount that you're going to have in your stockpile could change. And the hospitals will have to determine that as part of their effective written procedures for maintaining a stockpile. So now if you want to turn to the options, I'm going to briefly summarize them. Option one, for this option, you look at the types and categories and sizes of equipment that you've used during the preceding 2 calendar years before the April 1st that you're concerned about for establishing your stockpile or maintaining your stockpile. So you look at the preceding 2 years, which equals 24 months, and you divide the consumption, the aggregate consumption by 8 in order to get the 3-month average for your stockpile for April 1st. All right, in order to determine consumption for each category, type, and size of equipment, you can look at the total quantity that the facility received from all sources, except for those not for use by the facility. You can look at the total quantity ordered by the facility from all sources, except for those not to be used by the facility. You can look at the average monthly inventory, or the quantity distributed to units in which the employees provide patient care, and to units providing services that directly support patient care through any and all distribution methods, including separately chargeable and non-separately chargeable items. So you don't have to use the same consumption, the same method for determining consumption for each and every type of equipment. You can use, for example, the first method for determining consumption for N95s, and another method for another type of equipment that you're stockpiling. So that is option one. Option two is like the first option, except that we will cap the increase at 200% or double. So in the calculation for the second option, large increases from 1 year to the next, for example, from 2019 to 2020, are capped at 200%, which means that the actual maximum increase in your stockpile from 1 year to the next will be capped at 150%. So the stockpile never has to be more than 150% larger than the preceding year. And again, the methods for determining consumption for option two are the same as for option one, including the ability to use a combination of the listed methods for determining consumption. And then finally, option three, this option is also similar to option one in that you calculate how much you used during the prior 2 calendar years, and you divide it by 8 to get your 3-month consumption, except that you don't include in your calculation those months where the area in which the facility that you're building the stockpile for is located in an area that was subject to a governor's state of emergency for pandemic. So if there was this type of state of emergency during the 2-year period, you'll calculate your normal consumption by determining the average monthly quantity for each category of equipment and size and type, and you multiply that by 3. So you get the average month, not including the pandemic months, and you multiply that by 3. So those are the 3 options. I have a couple housekeeping items. Again, I couldn't hear all of what Kathy said, so forgive me if I'm repeating. We are recording this advisory committee meeting. If you, Cora, can you just confirm Kathy went over how to make a comment, right?
Yes, yes, she did. Thank you.
Okay, again, I apologize. And if possible, we'll see how many people want to provide input, but to start, if you could keep your input at 5 minutes so that everybody has the opportunity to speak. So having said that,
Chris, no one has raised his hand at this moment. Sorry, just wanted to clarify that.
Chris, your connection is not good. We cannot hear you.
Chris, we couldn't hear you. You were disconnecting.
Oh dear. So yeah, it says my connection is not working.
Why don't you disconnect the video, and let's say if just with the audio you have a better connection. It worked in the past, so let's try.
Can you hear me now?
Yes.
All right. So having said all that, Amalia, is there somebody who would like to speak, the first speaker?
No one has raised their hand at this time. Okay.
I see some hands going up now.
We have now a raised hand. We have Ronnie Verdugo. If you could please state your name and affiliation. Thank you.
Yeah, good morning, everyone. Ronnie Verdugo here with the California Hospital Association. First of all, I want to thank you and really all of Cal OSHA staff for your continued dialogue on this issue. From the beginning, CHA has been pretty clear regarding our position on these issues. We also clearly recognize that you know, the need for policies on this topic. I don't think anybody ever wants to go back to you know, sort of the issues that we ran into back in March when there was literally a global race for PPE. So with that said, before I get into the draft definitions Cal OSHA has offered, I do want to share a few thoughts. And I know it wasn't offered for today's discussion, but we still continue to believe that defining normal consumption defined solely on consumption during the 2019 calendar year is not only consistent with the intent of the bill, but more importantly, the plain reading of the statute. So I just wanted to share that thought. Now, as it relates to the options offered by Cal OSHA, just want to share a couple of thoughts. Option 1 and 2, unfortunately, in our view, are, I think, complicated to say the least, and likely not workable. And for the main reason being is that it would use and factor in pandemic level consumption into establishing and maintaining a 90-day stockpile, which would create an unnecessary strain on PPE supply chain, you know, as pointed out in our advocacy. But more importantly, to my earlier point, not consistent with the bill or, in our view, the plain reading of the statute. Of the available options, option 3 is closest to our understanding of the bill, given its recognition that our current state of emergency is an abnormal period However, we would argue that the definition should likely include any state of emergency, not just this one caused by the pandemic, because even things like wildfires, for example, could create strains and PPE supply challenges. So those are my thoughts, and thank you for the time.
Thank you.
Thank
Molly,
you.
who's
Yeah, we have
next?
Jen. If Jen, my apologies. I should have told you that when you're speaking, it's okay to turn on your video. So Jen, if you can state your name and affiliation, and you can turn on your video. Thank you. Go ahead.
Oh, hi. This is Jennifer Jean-Pierre. I'm trying to start my video, but it says the host has not disabled it. Oh, thank you. Hi. Good morning. My name is Jennifer Jean-Pierre. I am currently a registered nurse in the intensive care unit at Natividad Hospital in Salinas, California. I have been a registered nurse for the past 13 years. I am a member of California Nurses Association, and I am currently the Chief Nurse Representative of California Nurses Association here in Monterey County. I want to say thank you for the opportunity to comment today about what has been like to work during COVID-19 pandemic. Without the proper protective equipment, PPE as we all know, especially during the beginning of the pandemic. I would just like to share some of the things the nurses and myself have experienced in the last year fighting this pandemic in our community. In the beginning of the pandemic, as you all know, PPE was very scarce, and the N95 masks were not readily available for nurses and healthcare providers. They were locked away, locked and key. We would have to ask, our charge nurse or house supervisor for an N95 mask. And at that time, we had to justify the fact that we needed an N95, whether or not we were caring for a PUI or positive COVID-19 patients. So as you can see, during emergencies, they weren't not readily available. There was a delay in care for us to take care of our patients. And on top of that, we were not giving a good amount of N95 masks or pepper shields for our daily care for our intensive care patients, because they were trying to quote unquote preserve their stockpile, or say that whether or not they would give it to us, it was up to their judgment. And that was also a very big problem that we were occurring. During that time, N95 mask was used for multiple shifts between multiple patients, and we would have to save them and store them in manila envelopes and label them and date them. And we had an area in our donning area in our isolation unit where we would have kept all of those for each patient, for each person. And so as we know, learning in nursing school, those one-time use N95 masks are one-time use for one patient. We're not supposed to use them multiple times between patients throughout a 12-hour shift, and for many multiple shifts after that. So this is what we've been having to fight. Luckily, our union has stayed strong with the nurses, and we have not had to deal with something like that most recently, but this is what we have been having to fight for, and not willingly from our employer to give us what we need to take care of our patients, because we are frontline nurses. It was for the merely fact that we were pressuring them to make sure that we had what we needed to take care of our patients in our community. So I just want to say thank you very much for letting me to share the experiences that we had on the front grounds caring for our intensive care patients here in Salinas. But the fact of the matter is we were not given what we needed, and we had to stand strong together to get what we needed to take care of our patients. So thank you.
Thank you. Next in line, we have Wendy Macedo. And again, if you can please turn on your video if you can, and then state your name and affiliation. Thank you.
Thank you. Good morning. My name is Wendy. I'm currently a registered nurse at UCLA Santa Monica, and I'm a member of the California Nurses Association. I have been a nurse for 7 years. Thank you to everyone for this opportunity to comment today about what has been like to work during the COVID-19 pandemic without the proper protective equipment, especially at the beginning of the pandemic. So on my unit, we are the main COVID unit at UCLA Santa Monica. At the beginning of the initial quarantine, we were allowed to use 1 surgical mask per shift, and use it as long as possible. All surgical masks, N95s, and our bleach and alcohol wipes were removed from our isolation carts in every single pod. We have 8 pods total on my unit. They were all locked away. Because of this, we stopped doing our high-touch wipe down every shift. Our hand sanitizers were also removed. We only had the ones attached to the walls. There was only 1 box of surgical masks at the nursing station where they were to be monitored by the secretary. And if we were using more than 1 a shift, we were questioned. And this was for a surgical mask. I witnessed my unit director scold a float nurse. It was her first day back to work after maternity leave. She had a 3-month-old, and rightly so, she wanted to protect herself so as to not bring back anything to her son. She got an N95 elsewhere. But while on my unit, the unit director saw her and began to attack her, asking if she knew what our policy was and where did she get the mask from. We had a safety monitor on our unit who was a light duty nurse, and she was being trained to go around and report nurses who were wearing N95s when going into a COVID room. Management expected us to enter rooms with COVID positive patients with a shield and a simple mask, even after aerosolized procedures. They encouraged us to not go into those aerosolized rooms for an hour after. However, if the nurse needed to go in, we were only allowed to wear a surgical mask. Furthermore, someone finally blew the whistle and reported my unit to the Department of Public Health. It just so happened that the day that they came, someone received a heads up and all the carts were filled with masks and N95s. And so DPH believed nurses had adequate PPE, which we did not. Now, when we were allowed to use N95s, thanks to the new guidelines of Cal OSHA, we were expected to place them in a bag and reuse them. Later on, we were allowed to use more than 1 per shift, but we still had to place them in a paper bag, get them decontaminated through the UV light process. Those decontaminated masks were brought back to the unit and we were expected to reuse them. There was much confusion about this because guidelines suggested that it was a voluntary action if you wanted to reuse the UV decontaminated masks or not. However, in our mid-shift huddle message, it clearly stated that UV masks can be used immediately. To this day, administration has not actually said that it's a voluntary action. So I would just like to thank Cal OSHA for their guidelines. Thank you for standing with nurses. Thank you for giving us those guidelines in order for us to have adequate PPE. And thank you again for the opportunity to comment.
Thank you very much, and thank you for your work. Amalia?
Next we have Amy Arland, if I pronounce it correctly, my apologies. Again, if you can state your name and affiliation.
Yes, thank you. My name is Amy Arland. I'm currently a registered nurse at Kaiser Permanente in Fresno, and I've been a member of the California Nurses Association for more than 20 years. I also work in a designated COVID ICU department, and I have been on night shift the entire 20 years. The simplest way that I can put this last year into one generalized thought is simply this: infection control has gotten completely out of control. When costs went up over time and the distribution of supplies changed to the just-in-time model, only limited supplies like PPE were kept on the shelves readily available for frontline staff. And our local stockpile had been moved to a regional warehouse. The turnaround time for me to get an emergency supply order filled went from 1 hour to 12 hours on the night shift. And this was before the pandemic hit. We have a couple of golden rules that were completely ignored during this pandemic. One is that you never reuse a one-time use item. And 2, that you never wear dirty gear from one patient to the next. In the first few months of COVID, both of these rules were cast aside, and we nurses were instructed by management to suddenly wear our gear from one patient to the next and reuse PPE over and over in order to be good stewards of our supplies. We were given the impression that if we were not frugal in our use of our protection, that we would soon have to work without it. That made us feel very vulnerable, insecure, and we felt like that we could not trust our collective safety efforts to keep us alive at this point. We counted on our employers to keep us safe, but now we had huge doubts. Over the last 11 months, due to contradictory workplace safety guidelines, mismanagement, poor communication, and poor planning, Healthcare workers across the United States have been subjected to very cruel and unusual punishment, and many have chosen to leave the profession altogether rather than further jeopardize their lives. Here are just a few of the atrocities that I personally have had to endure in the last year. We stopped isolating for the usual germs such as VRE, MRSA, and other contaminants so that we could redeploy our PPE to the COVID units where it was felt it was needed more. I was told to wear a respirator only during aerosol generating procedures, and that the rest of the time I was only to wear a surgical mask in my COVID unit. Having to reuse my N95 mask for multiple days in a row and store it in a paper bag in a closet that was already full of dozens of bags of contaminated PPE. And then were worn again once that had been in storage for at least 7 days. Being pushed to reuse chemically reprocessed N95 masks, knowing or not knowing if it was a safe process or not, and the smell alone was so strong that it made me physically sick. Being given a handmade replacement shield for a capper, that was made out of what looked like saran wrap and electrical tape, and told that it had been cleared by EH&S as comparable, if not better, than the store-bought brands. Being reprimanded for wearing PPE that I had purchased to protect myself because I had felt like the materials I was being provided for at work were grossly inadequate. We should have learned better, especially after Ebola isolation protocols were put into place back in my hospital in 2014. There was a local emergency preparedness task force that was in charge of managing the stockpile, training the staff to use full CDC hazmat gear, and using a buddy system to observe for the application and removal of the PPE to prevent cross-contamination, as well as keeping staff up to date on rapidly evolving changes. But instead of rebuilding the depleted stockpiles after the creation of that task force, rationing and policing of supplies ensued with such vigor that something like a capper shield became a limited resource that had to be kept under lock and key for fear of theft and abuse. We were hailed as heroes on the outside of our hospitals, but inside we were being treated like thieves and irresponsible hoarders. And now that the PPE was being treated like an expensive limited resource that was running out, of course people began to be driven to hide supplies, to hoard them, and to make sure that they kept themselves with a backup emergency supply just in case. Well, let me tell you what we nurses have learned in the last year the hard way, and that is just in time is just too late. Thank you.
Thank you.
Thank you very much.
Yeah, I would just want to point two things. My apologies. For those of you that are having problem connecting, if we skipped you, remember that you can submit comments in writing. I just want to make sure that if I accidentally omit you or something, that my apologies. I want to make sure that you provide comments, and you have that possibility as well. So the next person that I have in the queue is Jessica Early. If you can, again, please state your name, your affiliation, and you can turn on your video. Thank you.
Sorry, this is
Jessica, you're muted. Sorry, you're muted. You need to unmute yourself.
Yeah, meanwhile, if anybody also has comments about the options and which option they think they prefer, that would be great as well. Thank you.
Can I be heard?
Yes, we can hear you now. Continue.
Thank you for this opportunity to share. My name is Jessica Early, and I'm here to speak on behalf of over 15,000 healthcare workers across the state of California, represented by the National Union of Healthcare Workers. NUHW members include certified nursing assistants, respiratory therapists, environmental service workers, mental health workers, and nurses in a variety of settings, including general acute care hospitals, skilled nursing facilities, and correctional facilities. Throughout the pandemic, our members have had to fight for adequate PPE to protect themselves as they do their critically important work. For our members, it is no exaggeration to say that access to enough PPE is quite literally a matter of life and death. I am here today to share our members' perspective on what constitutes normal consumption of PPE in the hopes that AB 2537 will be implemented in a way that actually guarantees access to safe and effective PPE. It has always been the position of NUHW that PPE should be used the way it was designed to be used in a healthcare setting. In other words, normal consumption means that all single-use disposable PPE should be exactly that, single-use. For example, disposable N95 respirators and gowns should not be used for an entire shift, nor reused, which is donning and doffing the same PPE item between different patients. So redoffing PPE you just used for another patient. Instead, a single-use PPE should be discarded after each patient encounter, and new PPE should be supplied for each subsequent patient encounter. This is how single-use PPE was manufactured to be used, and it is how healthcare workers have always been educated and trained to use single-use disposable PPE. Over the course of this pandemic, however, we have heard countless stories of healthcare workers across California being forced to use PPE inappropriately, including reusing the same N95 respirator for multiple 8 to 12-hour shifts, resulting in poor fit, saturation with moisture, and strap wear and tear. The fact that healthcare workers have had to do their life-saving work with PPE that is in such poor condition is outrageous. It is not proven to be safe nor effective to employ extended use, reuse, or decontaminated strategies to conserve single-use PPE, including N95. In fact, research shows that these methods decrease PPE safety and effectiveness. For example, N95 respirator straps wear out after 5 consecutive donning and doffings, which decreases the ability of the respirators to filter out airborne pathogens like SARS-CoV-2. In turn, the amount of PPE in a hospital's 3-month stockpile must be calculated based on the consumption of PPE when it is being used in the way that it was designed and intended to be used. Using PPE in any other way, but the way it was manufactured to be used in healthcare settings is not only abnormal, but dangerous. So we at NUHW feel very strongly that the option, the language in this bill needs to be specific to prevent the horrendous, inappropriate PPE that we've seen over the course of the pandemic. Because if the stockpile is calculated in such a way that doesn't reflect enough supply to use PPE appropriately in single-use fashion, then it really doesn't protect workers. And finally, we would argue that calculations of the amount of PPE need to reflect pandemic emergency type situations. The 3-month stockpile should be based on the volume of patients requiring workers' use of PPE during a pandemic, not during everyday conditions. Because if the stockpile is calculated based on the volume of patients when hospitals are functioning at typical capacity, such a stockpile will be quickly exhausted during a pandemic, and healthcare workers will be back in the very same position that they were for the past several months with not enough PPE. For a stockpile to be truly effective at preventing workers from the type of supply shortages we have experienced over the past year's pandemic, it must be large enough to account for an increase in patient volume due to a pandemic or other public health emergency. In other words, the 3-month stockpile of each type of PPE should be calculated based on the patient volume during 3 months of a facility operating at its peak capacity, not the much lower number of patients it typically treats during non-pandemic conditions. Again, I thank you for your time. I thank you for hearing from healthcare workers. This, again, is an issue of urgent and utmost life and death concern for our members and healthcare workers across the state. Thank you.
Thank you very much, Ms. Early. Amalia, who's the next speaker?
Yes, I have next in the queue, Michael Hill. Again, if you can turn on your video and state your name and affiliation. Thank you.
Hi, I have no video, so I'll just start. Hello, my name's Michael Hill, and I'm a registered nurse at Sutter Altabate Summit Medical Center in Oakland, California. I'm also a member of the California Nurses Association, and I've been a nurse for 34 years. I want to thank you for the opportunity to comment today as one of the many frontline nurses who have been caring for patients throughout the COVID-19 pandemic. Throughout much of the pandemic, we frontline nurses have struggled without the proper protection or proper protective equipment needed to care for our patients safely. I think it is important that the frontline professionals, us nurses at the bedside, set the standards for what is needed to properly protect ourselves in the current pandemic and well into the future, pandemic or not. From the very beginning of this pandemic, my employer, Sutter Health, stated that the COVID-19 virus was no more deadly than the flu. That was the mindset of administration at that time, so there was no urgency to protect nurses going forward expeditiously. In fact, PPE, like other supplies, were stocked under the just-in-time strategy, where supplies are delivered only as needed. This strategy has absolutely no room for error. That became very evident as the virus ramped up and hospitals began to compete for all types of PPE as patient beds quickly filled with COVID-19 patients. We too saw extreme shortages of PPE where PPE availability was rationed to nurses, requiring nurses to reuse masks and gowns multiple times while storing them in paper bags as though that would limit your contamination to the virus. Not sure who or what we were really protecting, the nurse or the mask or neither. Nurses even brought their own PPE into the units to protect themselves, but were threatened with discipline if they used it despite the lack of proper PPE availability. There was intimidation of nurses by management to only use certain masks in limited situations that clearly put nurses in danger. To this day, some of the PPE is locked away on units, and those in need to get permission from the manager to gain access to it as a way to conserve it for the future. There was also continued push to only use surgical masks as opposed to N95 masks. In some cases, to only use an N95 mask while performing a COVID test and revert back to no mask or a surgical mask for all other care. There was a time that nurses were only to wear masks in a patient's room, but not in the hallway. When positive patients came into the hallways, nurses had no protection, which resulted in one nurse death and another nurse being a long-term COVID patient herself. These policies to sacrifice the nurse at the expense of conserving PPE has resulted in numerous nurses being exposed to the virus from their patients, many becoming sick long-term and some dying. A tragedy that did not need to happen if the employer had simply stocked up for this foreseeable crisis. From the beginning, the nurses asked that hospitals administrators adopt the precautionary principle approach to preparedness that always errs on the side of safety in protecting the nurses and the environment in which we work. Enables decision makers to adopt precautionary measures when scientific evidence about an environmental or human health hazard is uncertain and the stakes are high. It was ignored. Preparedness requires that we always err on the side of safety to ensure that our nurses are protected by having the needed PPE readily available. Preparation has always been the key to dealing with any crisis. Don't let a decision be made here today that we only need to stockpile for the normal consumption of day-to-day usage while ignoring those days of crisis. We know that that was a failure at the beginning and resulted in many deaths and exposures as hospitals were unable to acquire the needed PPE. As the frontline professional nurses at the bedside caring for these patients, and you, the agency implementing AB 2537, it is our duty and responsibility into the future to never allow administrators of hospitals to put us in this situation of inadequate supply of PPE at the bedside again. Let's not repeat the past as we move into the future. Thank you for your time.
Thank you very much, Mr. Hill.
Next we have Rob Mutri from Cal Chambers. So Rob, you can turn on your video, and if you can please again state your name and affiliation. Thank you.
Hi, good morning. Robert Mutri, California Chamber of Commerce. Thank you. So I wanted to open up by first aligning myself with the comments from Mr. Verdugo. Broadly speaking, the concern on Cal Chambers side, looking at these three options, goes to the overall consumption and concern about balancing. I want to get out front first and say, of course, no one disputes that the past was unacceptable, right? These outcomes were not acceptable, and this worldwide shortage was unacceptable. Amongst these three options, we have concerns about including outlier years in the demand for stockpiling. And this relates to kind of a cross perspective with other regulations at Cal OSHA. You know, for example, with the wildfire smoke regulation, which recently came into effect, we have concerns that utilizing models that don't correct for outlier years will have hospitals kind of continuing to stockpile at a more aggressive rate when other industries also need these. For example, agricultural workers in the field need to be provided N95s under wildfire smoke reg, right? And in a wildfire season, that demand kind of needs to be recognized. So we have concerns that without dismissing or not dismissing, but without correcting for outlier years in some mathematical way, you have kind of at cross purposes with other areas that need protection. For that reason, we would lean towards option 2, which we recognize, appreciate the math, which corrects for outliers to a degree. But our favorite option would be year 3. We're a little concerned that the trigger of a state of emergency is maybe not the most discrete trigger, but we appreciate the goal there. We think that's the closest to an ideal way to kind of address that issue. So that's it for it. Thank you for your time.
Thank you. Rob, if I can ask the question, my apologies. Did you say year 3 or you meant to say option 3?
Sorry, yes, I meant to say option 3 if I said year 3, excuse me.
No, I needed to clarify. Thank you.
Thank you.
And my apologies, there was one person that raised their hand but put it down. Maybe somebody already made their comments, but other than that, please raise your hand again if you need to. Otherwise, Chris, we don't have anyone else in the queue.
Okay, well, yes, I see we now have Matt Leger. Mr. Leger?
Thank you, Matt.
Hello, this is Matt Leger with SEIU California, and I just want to first recognize and appreciate all of the frontline nurses who came and spoke today and other healthcare workers. I think SEIU shares this issue with CNA in terms of making sure that we have enough PPE for all healthcare workers. I just wanted to express some concern, and we're still trying to do some math on it. But really, the PPE issues were, of course, felt in acute care settings, but also were felt in long-term care settings. Our nursing home workers were experiencing many similar stories. So in terms of, having to wear raincoats, disinfecting the raincoats themselves, not having, appropriate masks. And so, my only concern, or our only concern with option 1 is really what is the impact going to be on nursing homes? And just making sure that they have enough PPE. It seems like the global supply chain is getting better, and we're encouraged by the federal government, but just wanted to express those concerns. So thank you so much.
Thank you. We have next in the queue, Curtis Lang. Curtis, if you can please turn on your video, state your name and your affiliation. Thank you.
Good morning, this is Curtis Lang. I was attempting to click on my video, but it's not allowing me to do so at the moment. But I'll go ahead and get started. Again, my name is Curtis Lang. I'm with the California Nurses Association. Oh, good, I can start my video. I got the little prompt here. Perfect. Curtis Lang with the California Nurses Association. And then again, thank you for the opportunity to comment on these options. I think I'll start with addressing a couple of statements that were made in regard to hospital stockpile, perhaps taking away PPE from others. I'd start by saying that all 3 options look like they would preclude hospitals from stockpiling to the extent that they would actually take away from others. We've also seen market forces rise to meet the demand for PPE. PPE shortages experienced earlier in the pandemic have eased as supply has increased. Reports state that the PPE market will reach $33.4 billion globally by 2027, and that's up from $12.9 billion in 2019, nearly tripling the revenue for the industry. And also, while demand for PPE increases, the supply has increased as well, so that a sizable hospital stockpile should not take away PPE from others who need it. And then another point is that this statute that we're all speaking about, requiring over 400 California hospitals to stockpile, also creates a PPE supply chain pipeline. So that's what I want to say around that issue. But with regard to the various options, I'll speak to option 1 and then option 2, and then I'll allow for my colleague to go ahead and speak to option 3. So I'd like to say I have a question. First, I'll have a comment. I'll talk about option 1. Method 4 to determine consumption within option 1 is problematic for us because using the quantity distributed to units could inadvertently undercount consumption because it does not reflect the reuse of single-use PPE that is currently happening in facilities, as nurses have testified to today. A November 2020 survey of our members found more than 80% of nurses report they are reusing at least one type of single-use PPE. At many hospitals, N95 respirators are still being rationed, as we heard today, with nurses getting only 1 per shift instead of 1 per patient. It is important to note, however, that under Labor Code Section 6403.3, Section C2, single-use equipment in the stockpile should be unexpired, new, and not previously worn or used. So in terms of questions about option 1, I see that there was a subdivision F and wanted to understand why that might be there and why that's necessary since it's a part of the statute. And that's the part that talks about the employer shall establish and implement effective written procedures for periodically determining the quantity and types of equipment used in its normal consumption. And then there's another section that talks about except for those not, so this is on option 1, and it has a section that talks about except for those not for use by the facility. It's added to the first 2 methods of determining consumption. Don't understand why that's there. And then we have a question around the purpose of the note at the bottom of option 1 that indicates the employer may use different methods of determining consumption for each category and type for equipment. Have a question around that and why that's there. Now, with respect to option number 2,
Curtis?
Yes.
Curtis, maybe we can address those questions and then go on to option 2 if that's
sure.
If that works for you.
Absolutely.
Okay. Because I'm wildly writing down your questions. I just want to maybe respond to them and then you move on. So
perfect. That makes sense.
Regarding the first paragraph that says Labor Code 6403.3 requires an employer establish and implement effective written procedures for periodically determining the quantity and types of equipment used in normal consumption. So you're right, that does exist in the statute. The reason why it's repeated here because it does affect the calculation, right? Because you might, let me turn that off. You might, if you just look at the pure amount used during the prior 2 years, that wouldn't necessarily account for any change in the hospital. For example, if you have more employees, you have more units, you have fewer units. 2 years use under different conditions might not inform you properly about the size of your stockpile, if you understand me. So what this requires is, as part of your effective written procedures, you have to consider all of these facts about your consumption and your need in order to determine what 3 months of normal consumption will be for your stockpile. So Cora, Dee, Jamalia, did you have anything about that question that you wanted to add?
No, this is Cora. I think that's the explanation. To allow, according to the law itself, to allow for periodic looking into the consumption and corrections due to that.
Right, because if you had a bunch of units, at the beginning of this year, your consumption is going to be much greater, and under your effective plan, you have to take that into account. So moving on to the 4 methods for determining consumption, methods 1 and 2, have except for those not for use by the facility. We have heard that some hospitals actually purchased additional equipment to give to firefighters, for example. And so this clause is added so that they are, air quote, penalized, end quote, for having purchased PPE to donate, by then making them account for that in their calculation moving forward. And then last, I think you asked about the note at the end of 4. The employer may use different methods of determining consumption for each category and type of equipment. So this means that, the list of equipment that you have to have in your stockpile is fairly long, and you can use a different method of calculating consumption for each type or size of equipment. And you can choose from this menu of, 4 options for determining, for example, maybe you used, for determining N95 filtering face piece respirators, you're going to use the total quantity received in the facility from all sources except for those not for use by the facility. And then for surgical masks, you might, your records might best work for option 3 or option 2. So you can use a combination of the options listed in order to get to your consumption levels. Does that make sense?
Yes, thank you for explaining that. Appreciate
sure, you want to
that.
go on to option 2 now?
Sure. So for option 2, we had those same questions, but you just cleared those up. In terms of comments, we're concerned about the cap in general because the way that it's laid out here we would be capping a year like 2020, which is a pandemic year, and we know just based on the testimony today that 2020 consumption probably won't be adequate and high enough. And we're concerned that the 200% cap of the first year, alternatively, if we do move forward and there is a cap, we're concerned that the 200% cap in particular of the first year's consumption when calculating the average consumption may not be adequate. The percent cap may need to be a little bit higher, maybe 300% or higher, in order to ensure that the calculation captures consumption that will produce a large enough of a stockpile. And that's all I have on 2. Yeah, that's all I have for the moment. Thank you.
All right, thank you very much.
Thank you. So no comment for option 3. I don't want to cut you off. Sorry, Curtis. Just wanted to make sure.
I don't know if my peer was able to get on, so I don't see. Is Saskia Kim in the queue by any chance?
Hold on a second.
Her hand is raised, yes.
Perfect. Then I'll let her take on that one. Thank you for the opportunity.
Okay. So next we have Jay Belden. If you can turn on your video and state your name and affiliation.
Sure, thanks very much. My name is Jason Belden. I'm the Director of Emergency Preparedness for the California Association of Health Facilities, and we represent the skilled nursing facilities throughout the state of California. And I want to thank you guys for the opportunity, and I want to say thank you immensely to any of the caregivers and frontline staff workers that are engaged in this call. Thank you for everything that you've done over the last year, and your sacrifice that you have made has made a difference in the lives of our Californians, and we're immensely grateful for that. That being said, the California Association of Health Facilities has concerns about the use of outlier years to determine capacity, especially as it relates to downstream effects on skilled nursing facilities' ability to purchase supply of PPE for their residents and staff. Currently, most, if not all, of our skilled nursing facilities are still on allotment orders. We cannot order sufficient supply to go back to disposable use, and any increase in demand from supply side, especially one as substantial as this, will further delay our abilities to be able to convert back to disposable use and getting back to being referring providers where we can get these folks out of our buildings. But until that time, PPE is not fixed in skilled nursing, and folks that think they are. We have two major suppliers. They're both the same major suppliers as hospitals, and we take a back seat to them in everything we do. And so our folks are still ordering 75% of their traditional orders based on 2019 orders. We cannot even order enough now to meet demand. Any move to increase supply is going to have really significant impacts within skilled nursing care. I know there's other demands from other employers for respiratory protection. Those issues are not going away, and we would like to at least encourage Cal OSHA to reconsider putting such an emphasis on that when there is a distinct need within the skilled nursing communities right now. And we don't want to draw attention away from those folks. So I appreciate your time and allow me to talk. Thanks very much.
Thank you. Chris, and if I can make a statement or suggestion, because you said two manufacturers that are providers, I just wanted to bring to your attention that Cal OSHA has on their website a list of manufacturers or people that you can go and buy N95. I'm sorry, I should have mentioned that earlier, and I forgot to let you guys know is right now up to 18. That the division is following up with them and talking with them. These are, again, to purchase N95 respirators. My apologies, Chris. I should have brought that up. Sorry.
Oh, no, that's great. And Mr. Belton, I have a question for you. Have your suppliers or the suppliers that your constituents work with, have they given a prognosis about when they think that the supply chains might clear up and be able to, provide more? Oh, you're on mute. I can't hear you.
You're muted. Sorry. Let me see.
Sorry. I always do that. I apologize. Yeah, so Medline and McKesson are the two largest suppliers to skilled nursing facilities. Both of those folks have been on and off of allotments based on, what their supply chain is. I realize there's many other people that have come onto the marketplace, since then. Some are vetted, some are trusted, some have been selling counterfeit PPE. There's a lot of unknowns with unvetted or untested suppliers. And when we're involved in a pandemic, not only do we have to get, respirators, but we have to get specific make, model, and size of respirator that is consistent with the fit testing that we've done. So there's a process, and it's not exactly, let's just say I can get 1,000 masks from McKesson, and normally, but now McKesson says, well, okay, you normally order 1,000 masks. We're going to give you 750, but we can't give you that make, model, and size because we don't have those in stock. So we're going to give you this other make, model, and size. And that has been a pretty consistent thing for the last year. And folks have been trying hit and miss, but it is not consistent, and really it is limited in capacity. And then not to mention the exponential increase in cost as well. I certainly know we're not talking about cost in this, but it is a definite factor for us on the downstream side.
Is there one of the options that you can support then?
Out of these three, obviously the option 3 would be the one that we would support the most, but any of the options are going to have downstream effects on the skilled nursing facilities. We just want folks to be aware of that.
Thank you very much.
This is Cora Gerga. I just want to add this. Mr. Belton, thank you very much for your input. I just wanted to make it clear that what our charge during this advisory process is to define normal consumption, because with the arguments on both sides of the issue, the law is already adopted and effective. So it's not as if we are, through this process, imposing any requirements of the employers. The requirements are imposed by the law. And we did not have, I mean, it went through the legislature and signed by the governor. So it was not necessarily OSHA's action that led to this. And in terms of the 3 months having it, let's say, available, it doesn't mean that people would use more. It means that you would, let's say a facility, a hospital would purchase more equipment to have for rainy days, basically. So it's sort of like a moving, it's a moving amount that stays there. It's not that it's gone forever. It's there for the use of the healthcare worker. So instead of buying 3 days or having at hand available 3 days worth of supplies, the idea would be to have a longer time worth of supplies. And of course, we appreciate your input, and you know, we understand that we ourselves identified more vendors, and we cannot say that we vetted all of them, but our own inspectors, when they go to all of the places of employment, have to use this equipment, of course, in much smaller amounts. So thank you very much for the opportunity to respond.
Okay, we have one more person in the queue. Chris, can I continue, or do you have questions? So I don't want to interrupt you.
No, continue.
Okay, the next person we have is Sasha Kim. Again, if you can state your name, affiliation, and you can turn on your video.
Hi, this is Saskia Kim with California Nurses Association. It's still preventing me to start my video. Oh, there we go. Thank you. Appreciate that. Good morning, Saskia Kim with the California Nurses Association. Thank you for the opportunity to comment on option 3. The normal consumption calculation in this option does not include any time periods when a pandemic state of emergency is declared, as was talked about earlier. This is problematic, and CNA has significant concerns about this option for the following reasons. First, the effect of this language would be to only consider time periods when practices like just-in-time purchasing were in place. So for example, there is no pandemic state of emergency in effect during 2019. And the legislative history demonstrates that we shouldn't be relying on 2019 only. And 2019 levels reflect hospitals' just-in-time practices where they order and stock only what they need at that moment in time. That doesn't work in an age of pandemics. You've heard our nurses tell you why just-in-time is just too late. And this is not our first pandemic, and it won't be our last. And even the head of the Hospital Association has indicated that just-in-time purchasing is inadequate to meet the needs during a pandemic. Hospitals are responsible for ensuring they have enough PPE during periods of fluctuations, and it's important to consider what's normal for a hospital. Hospitals have to prepare, and when they prepare, they have to project. CNA believes normal for purposes of the PPE stockpile required by AB 2537 should include fluctuations which cover both pandemic and non-pandemic time periods. In addition, what's normal can change over time. So for example, the present day new normal is to wear masks whenever one is outside one's home. Also, option 3 would only take into account consumption during those periods when a pandemic state of emergency is not in place during the preceding 2 calendar years. So walking through that operationally, as a result, because the governor declared a state of emergency March 4th, only consumption during the months of January and February, and maybe 3 days in March, would be considered for purposes of determining 2020 consumption, and therefore how much PPE needs to be in the stockpile. So under option 3, those 2 just-in-time months would be multiplied by 3. This is problematic and would lead to an absurd result that the legislature clearly did not intend. And furthermore, considering only non-pandemic state of emergency time periods to determine consumption would frustrate the purpose of AB 2537. As expressed in the legislative findings and declarations in the bill, the purpose of the bill was to ensure frontline nurses and healthcare workers who need protection have access to the respirators and other PPE they need. So relying only on non-state of emergency time periods to determine consumption would mean relying on just-in-time levels, which again, as you've heard from our nurses, do not ensure that they have the protection they need. And then as Curtis mentioned, option 3 does contain language that was included in options 1 and 2. Thank you, Chris, appreciate you and others answering those questions. And then just very quickly on the ledge history comment, some have really tied the language in AB 2537 and reference to the 2019 calendar year to assert that that was meant to inform the definition of normal consumption, but that simply wasn't the case. There was language, and there is language in there that ties allowing Cal OSHA to request the hospital's highest 7-day consecutive daily average consumption of PPE during 2019, but that was meant to provide Cal OSHA with a reference point when evaluating hospital stockpiles. So because consumption in 2019 was lower, it was thought if Cal OSHA evaluated current stockpiles and then measured that against the highest 7-day in 2019, they would know that the current stockpile was insufficient. And then again, language specifically basing consumption on that highest 7-day was actually deleted from the bill. So we believe that demonstrates clear legislative intent to separate the highest 7-day reporting from the amount of PPE that's necessary to include in the stockpile, and actually is legislative intent that demonstrates that the sole use of 2019 consumption data should not be used to define normal consumption. Thank you again, appreciate it.
Yeah, Ms. Kim, this is Chris. So which option then between 1 and 2? If you'd like to say which you prefer, if not.
I think we are more comfortable with option 1, but I do note my colleague Curtis's comments and questions on that. So,
okay.
Especially I think that subdivision 4 that we have concerns about allowing for the potential for reuse.
All right, so option 1 then as modified by the questions. Got it.
Great, thank you for the question. Appreciate it.
Thank you very much. Are there any other questions of Ms. Kim? Okay, moving on to the next speaker, Amelia.
Yes, so the next speaker that I have is Gail Blanchard-Sager. Gail, if you can please state your name, affiliation, and you can turn on your video. Okay, so right turn.
Hi, good morning. Thank you. This is Gail Blanchard-Sager with the California Hospital Association. And I do appreciate the opportunity for this continued dialogue. We've been talking about this issue for quite some time. There's obviously a lot of moving parts, so appreciate the continued discussion. So I do want to also thank our frontline healthcare workers that are on the call today and who are providing their firsthand experience. And do want to share that I think as we've been saying from the beginning, no one wants to experience what we experienced last spring, and that really, we appreciate the intent of this bill as well as the companion bill SB 275. That really is an effort to try to make sure that that doesn't happen again. Kind of the global pandemic, global demand for all of the same PPE all at the same time. But I do want to kind of step back and take a little bit of a holistic view of this. In looking at this bill, we're focused on the hospital stockpile, but hospitals and their employees together are not kind of the only players in this, on this point. The state is working, and I'll talk a little bit about SB 275, which again is a related bill on this topic. The state is working on what a stockpile should look like, local EMS, the manufacturers, distributors, the federal government. And so, I think while there might be a little bit of skepticism because of how things played out last time, during Ebola, the Ebola situation, I think there is, kind of a real recognition that things need to change, and we're all working together and with that goal. So really, I think it's important to look at the hospital stockpile in that global sense. And I do just want to touch on SB 275 for a moment. While this bill and SB 275 don't have a clear linkage, obviously because they're on the same subject, hospital stockpile as well as other, stockpile, the state stockpile, we do kind of need to recognize what's out there. And SB 275 does create an advisory committee to look at PPE and particularly a 45-day surge level PPE stockpile or inventory for hospitals. And so, you know, when you compare the phrase normal consumption with 45-day surge, right? They've got to be two different things. But in any event, you know, the state is looking, and I'm in conversation with Cal OAS, and I know that they are looking at the state stockpile as well. And so we are moving towards another set of regulations, hopefully in 2023 or soon thereafter, that's going to take into account that larger picture. So in kind of from our perspective, this activity around this definition of normal consumption, this stockpile, is a bridge to get us to that kind of larger, more holistic discussion. So I just want to, again, put it in context of all the other work that's happening. I also want to ground us back into the actual language of 2537, which is 3 months of normal consumption. And we have provided lots of input that I won't reiterate here on the definition of normal consumption. The plain meaning of normal consumption would not include a once-in-a-lifetime pandemic, which by definition is abnormal. So, you know, in some respects, I think going back to what my colleague Ronnie had stated, a definition of normal cannot include pandemic level. So for that reason, you know, options 1 and 2 really, to us, are contrary to the clear statutory language. So I do just want to address a couple of the comments on the just-in-time inventory system that hospitals, most hospitals did utilize prior to 2020. And I want to make a distinction between the just-in-time system and actual consumption. What we're talking about here is looking at consumption. How are we going to define normal consumption? And so I want to distinguish that from the just-in-time system of inventory management, meant that hospitals, for the most part, and you know, there's over 400 hospitals in California, so we've got to generalize here. The just-in-time system of inventory and supply management meant that hospitals had on hand about somewhere between 3 and 14 days on hand. This bill would require that hospitals have 90 days on hand. So by its definition, even using 2019 data, we are, you know, dramatically increasing the amount of PPE that hospitals will be required to have on hand. So I appreciate the concerns with the just-in-time system, but by its definition, this new law is changing that. Hospitals will no longer be able to have 3 to 14 days on hand. They are going to be expected to have 90 days on hand. So I just wanted to clarify that. And one other point I want to make on the issue of including pandemic level consumption in the definition of normal consumption is to kind of point out that this particular pandemic impacted the state very differently in various regions, right? We were all under a stay-at-home order at the same time. We were all under the second stay-at-home order at the same time. Now, some counties are in purple tiers, some are in orange tiers. So we're all kind of trying to do the best with respect to kind of the infection control component as a community. But our hospitals, if you look at the impact on particularly our hospitals in Southern California, in LA, kind of over a longer period of time, have been significantly more hard hit than our hospitals in Northern California, for whatever reason. So my concern about utilizing pandemic level consumption is that small standalone safety net hospital in LA that was just inundated with COVID patients is going to have an astronomically large stockpile, while a Northern California hospital of the same size might have something closer to 2019 level because they didn't have that many COVID patients. And so the adverse impact on particularly our small safety net hospitals in the LA region and the Inland Empire in San Diego, that is a very real concern. And so it's going to strain an already strained safety net hospital system. So I can provide more detail to Dash after this call, but I think it's something that really needs to be seriously considered as far as the policy discussion. So I think to close, we do believe that 2019 consumption is the right measure. It is consistent with the statute, and it does provide a substantially more amount of PPE that would be available to kind of, again, bridge that period where all of those other resources are going to come into play.
Thank you very much. Amalia, I don't see any further hands.
I don't see anyone else with comments. Sorry, unless I'm missing someone. I don't see anyone. Okay, I see one more. Sorry, my apologies. Sasha Kim. Again, if you can state your name and affiliation, because it's being recorded, and if you can turn on your video too. Thank you.
Thank you. I just want to make sure everybody else had a chance to comment before I jumped right in again. Appreciate it. Appreciate those comments. I just wanted to raise a couple of quick issues. On SB 275, I just wanted to quickly mention that, of course, is a separate bill, creates a separate process to determine PPE stockpile size. It has its own regulatory process, its own advisory committee, and a timeframe that is several years out. And so that is all separate. And then also, you know, the concern or argument that the terms used in that bill somehow inform the definition of terms used in AB 2537, because SB 275, as Gail mentioned, uses the terms surge capacity or surge consumption. And, you know, at this point, that term has not been defined, so we don't know what it means, but it's, you know, I think there's an assumption that that means a pandemic level when that may very well not be the case. I mean, it could be a surge is, you know, an increase for a moment in time rather than some kind of sustained increase. And so I just wanted to kind of briefly mention those points on SB 275. And then just very quickly on the, you know, just in time versus consumption, I understand the distinction between just in time being an inventory management tool or practice, but I think the point here is that we have definitions that take into account that kind of inventory management or practice, right? So the amount of consumption is based on what's ordered or what's received or with a monthly inventory. So it's all tied to that inventory management and that just-in-time model. So just wanted to kind of make that quick point. Thanks again for letting me jump back in here.
Thank you. And I just want to remind anyone, if you want to comment, that to make sure you raise your hand. If you have a question how to raise your hand, I want to make sure I don't accidentally miss you. Okay, we have one more person. Gail Blanchard-Sager, again, sorry, if you state your name, affiliation, and thank you for turning on your video.
Thank you. Gail Blanchard-Sager with the California Hospital Association. Maybe Saskia and I should have an offline conversation so we're not going back and forth, but I just wanted then to respond to her comments. SB 275, yes, did end up as a separate bill, but there was one point when basically the language was joined. And so in SB 275 at one point, and I don't have the date, I think it was August, I don't know, 25th or something, where the language of 2537 and 275 were in the same bill. And I think the language was a little bit different at that time. I think it said daily consumption, not normal consumption. But I think, again, kind of need to look at this holistically. And on the issue of the just-in-time, again, just to clarify a little bit more, just-in-time did not drive consumption. Consumption drives just the just-in-time product. So how it works is that, you know, a hospital puts their orders in based on what they need, and then their distributors will kind of do burn rate, and now we all know these terms that we never knew before. We'll kind of do a burn rate calculator, you know, back in 2019 and say, okay, based on what they're ordering, you know, we need to get them more because they're using more. So I just want to be clear on that, that the just-in-time inventory system did not drive consumption. It's actually the other way around.
All right, thank you. I don't see any further hands.
I don't see any either.
Right. All right, well, if nobody has any additional comment, then I think we can close this pre-rulemaking advisory committee. Thank you, everybody, for speaking. I've been taking notes. We've also got a recording. We will consider all of the comments and discuss them before we determine, you know, which option that we're going to move forward with. So Cora, I see you've activated your video. Did you have something you wanted to say as well?
Well, not really, but I realized that there's enough bandwidth. I think that it's important to remind people that they could write input or feedback or comments to us until the following Friday, which is the last work day of February. And we have the email address to which we would like the comments to be sent. We initially sent a slightly wrong email address, but we corrected it. So we just wanted to make sure that everyone knows that we urge people, if they have comments besides what was today. So after hearing everyone talking, maybe you have additional thoughts. We welcome them by next Friday.
Okay. If there's nothing more, then I think we'll sign off. Thank you again, everybody, for contributing. Your input is extremely valuable to us to, you know, assist us coming up with an effective definition of normal consumption.
Chris, can I just say one thing? Can you type, or Cora type in the chat to everyone that email address, just so they can have it on there?
Yeah, Cora, do you have it handy? Cora, you're muted.
I said, I will have it in a second from now, okay?
Okay.
Let me get it here. I want to copy it correctly, so I'm going to put it there.
If you've already sent comment to the other address, we do have it. It's just this is a better address.
Okay.
All right.
I think this is it. Chris, does it have an underscore between legal and oak or no?
Yes, I have no idea.
Oh, let me try again, okay? Let me make sure that I'm getting the correct address. Everyone has so many email addresses that are now, you know, like mailboxes. So let me try one more time. See, okay. Yes, it did. I just wanted to double check. Okay, I did send it. Thanks for your patience.
Should we give them just a few seconds before disconnect so anybody has to copy it?
I'm waiting for it to show up. I see there's 9 new messages. And I see that the email address has appeared in the message in the chat column. So if you'd like to take it down, we'll give you a minute or so and then we'll disconnect.
Yes, feel free to log off, everyone, once you have that down.
It was on the latest meeting invite that we resent last night. So it's in the invite, in the email invite itself, and also it's on the agenda.
Perfect.
Okay, I think that's enough time then. Again, thank you everybody for your participation, and we will meet again on this in the future. Thank you.
Thank you very much, everybody. Stay safe for the weekend.
Thanks.
Thank you.
So Cora, you can sign off too, otherwise it'll keep recording.
Yes.
All right, call me if you need anything.